Hello, everyone, and thank you so much for joining our webinar today. We have Dr. Sanjay Mathew, and he is the Johnson Family Chair for Research in Psychiatry, professor with tenure in the Menninger Department of Psychiatry and Behavioral Sciences, and director of the Mood and Anxiety Disorders Research Program at Baylor College of Medicine. He is also a staff psychiatrist at the Michael E. Debakey VA Medical Center in Houston, Texas. He completed his psychiatric residency at Columbia University and the New York State Psychiatric. In this webinar, Dr. Mathew will review the history of ketamine for the treatment of serious depressive disorders. Ketamine is an anesthetic drug which has recently been repurposed at low doses for the treatment of severe mood disorders, PTSD, and suicidal ideation. The mechanism of activity in the brain involves changes in the activity of glutamate, which is the primary amino acid neurotransmitter in the brain. Glutamate is critical for fundamental brain activities such as learning and mood. This webinar will review the history of ketamine for the treatment of serious depressive disorders, and also additional drugs in development which impact glutamate and one of its primary receptors, NMDA, will also be discussed in this webinar. Welcome, Dr. Mathew.
Thank you very much, and thank you for organizing this for everyone at the International Bipolar Foundation. Next slide, please. Okay, this is just a note about the International Bipolar Foundation, and we'll get to that at the very end. So today I wanted to speak about, by way of introduction, what are some of the unmet needs in terms, I'll be focusing on drugs specifically, and there are many great unmet needs in this area. And then we'll go through some of the history of ketamine and how it's gotten to be used as a treatment. Of course, off-label. At this point, it's not FDA approved for anything in psychiatry, and we'll talk about where that stands with respect to getting approval. And then talk about, towards the end, some of the other drugs that impact this same system, the glutamate system broadly, and where we are with that line of research. Next slide, please. So the unmet needs are great, and it's quite remarkable that there have been a number of antidepressants, mood stabilizers, drugs used in bipolar disorder, bipolar depression in particular, but they all have limitations. Many patients don't fully remit. Many patients may have a therapeutic delay before there's a good response. Even if there is a response, there can be relapse, and relapse often is the norm following successful treatment. And then, interestingly and quite alarmingly, that our drugs that we test for depression and bipolar depression exclude the sickest patients, those who are at the highest risk for suicide. So we, in fact, know very little about that, how they impact suicide risk. And then there's a limiting understanding of the biology and the pathophysiology of these illnesses, making it particularly complex for drug discovery. If we don't exactly know what are the right targets to go for, how can we make progress? Next slide, please. And this is an alarming figure that really, while we've made progress in a number of medical areas in terms of cancer, risks of death, in terms of cardiovascular mortality, you look at how flat the rates are for death rate from suicide, which is higher in men than women, but over certainly the last decade, we've made very little impact in decreasing these numbers. Next slide. And this is quite an alarming schema as well. Many of you are familiar with this. This is listing the most common causes of death by age group. And in the far right, you see for all ages, suicide remains number 10 for leading causes of death. And in some populations, some age groups like adolescents and young adults, it's as high as number 2, ahead of homicides and all other forms of causes of death. Next slide. And part of the reason, perhaps, is we have such a crude understanding of these illnesses, depression, and so on, and all of our drugs essentially work on the same 3 neurotransmitters or neurochemicals, the serotonin, norepinephrine, and dopamine, and they've been like that for many years, and we just have not discovered new targets, unlike in cardiovascular medicine, where you can see on this graph many new targets, many new mechanisms have been uncovered over the last 50+ years. Next slide. So one way to think about drug discovery is trying to identify completely new molecules that have never been studied before or tested before. Another way, and perhaps a more cost-effective way and a quicker way, is to repurpose old drugs for new indications. And this is sort of this idea of repurposing drugs. Next slide. Next slide. Next slide, please.
I am advancing.
So,
is it?
Yeah.
Okay, perfect.
Yeah, that's fine. So, and the idea of repurposing, just to touch on that, this is what we do in bipolar disorder. Of course, all the anticonvulsant medications were used in neurology and epilepsy, and we repurposed them for bipolar disorder. And we do a lot of that in medicine. And the ketamine story, which we'll talk about, is a prime example of repurposing, which is dramatically cheaper and cuts the time for drug development in approximately a half. So what is glutamate, and why is glutamate an important system? It's the most common excitatory amino acid neurotransmitter. It's found pretty much everywhere in the brain. 80% of brain cells or neurons use glutamate as a primary neurotransmitter. So it's fundamental to energy in the brain and metabolism, and it's distributed in several areas and different compartments. Next slide. Next slide, please. So ketamine works on a specific glutamate receptor called the NMDA receptor, and it works by working within the channel of the NMDA receptor. It binds to the so-called PCP site, or the angel dust site. You know angel dust as a drug of abuse. The idea behind ketamine was, could you develop a safer version of angel dust? And that's how the work in the 60s was developed as an anesthetic, safe alternative to angel dust. Next slide. And this is just a schema of the so-called NMDA receptor and next slide. Are you advanced? Yep. So it goes into an activated state when glutamate binds to the specific site. Then glycine is also an amino acid neurotransmitter that binds at a so-called coagonist site. Next slide. And there's a process called depolarization in the active state, where then calcium comes through the ion channel, and there's activity in the cell. Next slide. So this was, ketamine also, besides being an anesthetic, as is a drug of abuse. It's a Schedule 3 by the FDA, meaning there's a high potential for abuse. And so this is well, why do people abuse ketamine? It's often for the feelings of feeling light, feeling happy, joyful, feeling connected to others, often used in conjunction with dance parties and so on. And so that's where ketamine has gotten sometimes a bad name, because it certainly can be abused. Next slide. And there's been, I mean, a lot of media coverage about this. It's been in the popular press, numerous articles written about it. And now around the country, there are numerous ketamine clinics. And the interesting thing is there's been probably a lot more lay articles in the public media than even research articles. So one word of caution regarding that is the number of patients enrolled in clinical trials have not been that many, certainly not anywhere on the order of what you'd see with currently available treatments. Next slide. So this is a study which was actually a replication study of an NIH, or of an initial study out of Yale. These were patients who were inpatients at NIMH, a clinical center, who had treatment-resistant depression. These patients had unipolar depression, did not have bipolar depression. And what was found was a single low dose. This was what's called a sub-anesthetic dose. So patients were awake throughout. They were not sort of given anesthetic level doses. They were given a 40-minute continuous infusion. And in orange on the left, you could see the ketamine group had rapid reductions in the depression scale, which was sustained through several days. By day 7, most patients had gotten back to their baseline levels. In the black, you see what the rates were for placebo. So placebo really was not helpful at all. The response rates at 24 hours after a single infusion was about 70%, and that remained above 50% for several days. So this was quite a striking finding, because these patients had failed a lot of antidepressants, were quite refractory in that sense, and yet a single infusion of a drug caused this very rapid, in some patients, a relatively miraculous change. Next slide. This was a study that we were involved in. It was a 2-site study in Houston and New York, and it looked at one of the issues with ketamine research is it's awful hard to blind ketamine. And a patient who gets ketamine often may know that, because they may have feelings of floating above the bed. They may have altered sense of their physical appearance. They may have blurred vision. There's a number of short-term acute side effects, which makes it very difficult to blind in a true double-blind manner. And so we did a study looking at another anesthetic agent called midazolam, or so-called Versed, which is something we use all the time for short surgical procedures or colonoscopes or other gynecological procedures, and to use that as an active comparison. We didn't think it would have any antidepressant properties, but could be a good control. And what we found, that even with a credible control, ketamine still had high rates of response in a very similar fashion to the NIH trial. So about 2/3 of patients responded in a short period of time with the 40-minute infusion, which persisted up to about a week. Some patients in that study remained well for up to a month after the study was finished, but most patients relapse somewhere between the 7-day and the 14-day period. Next slide. And what are the symptoms that get better? across the board, there was improvement relative to the control. Some of the most notable symptoms were pessimistic thoughts, lassitude, concentration. So often patients would report the next day, 24 hours later, after any acute sedative side effects had worn off, they felt more motivated, they felt more activated, and they felt like they didn't want to procrastinate anymore. We had patients who said, no one described being ecstatic or joy, but they often would describe the release of negative feelings, the release of negative weights or burdens, and so that in itself was allowed for optimism that they could actually go out and do stuff. And for some, it was as simple as going out for a walk, taking their pet for a walk, or walking through Central Park, or cleaning the dishes that had been stacking up in their kitchen, or going through the mail that had been stacking up over weeks. And so essentially having the energy, the motivation to not procrastinate anymore. And so that was quite notable. Next slide. And so looking at across, and this is a meta-analysis of a number of studies, and this was published last year. And as you can see from the sample size, there aren't, a huge number of patients in these studies across 5-6 centers, about 150 patients. The effect sizes, meaning the drug placebo differences, are quite large at 1 day, more modest at 1 week. Next slide. And next slide. Skip that one. Next slide. So there have been 2 studies that I'm aware of that have looked at ketamine for acute bipolar depression. So these are patients who ketamine is added on to a course of lithium or Depakote for patients who haven't responded to those drugs. And many of these patients have failed previous antidepressants. And this study was done by the same NIMH group, led by Carlos Zarate, and found very similar effects as the unipolar studies with the same dose. So as you can see here, there was a rapid benefit to ketamine that then sort of by day 7 comes back to baseline. Next study, next slide. And this is another study published by the same group showing about more than half of patients responded within a very short period of time. And you can see the rates at 1 day, 2 days, 3 days. These are proportion of responders, which again are very similar to what we see with unipolar depression, 50, 70%. Next slide. And this was interesting finding that the suicidal thoughts, now it should be noted that patients in these studies were not actively suicidal. They didn't have a imminent intent to die. There was no sort of active plan to kill themselves, although they did, many of them had passive suicidal thoughts or thoughts of death. And you can see here that the ketamine group had reduction in the severity of these thoughts over time, which corresponded to its reduction in depression. So since this study, there have been a number of studies looking at ketamine's impact on suicide independent of its effects on depression. And some of these studies have shown an anti-suicidal aspect of ketamine, irrespective of its impact on the underlying depression. So that's interesting work that's in progress. Next slide. And so this is the replication study. So the second study, and interestingly, there was good effects in both bipolar 1 and 2. So there was equally robust effects across both these diagnoses. Next slide. One of the very difficult things to treat for patients with bipolar depression are the anxious features, the generalized anxiety disorder features, the panic features, PTSD-like symptoms, and this study suggested that ketamine was equally effective in these anxious bipolar depressed patients compared to those without anxiety. So that's important because what's often left over after the resolution of the depression are these GAD worry type features or anxious apprehension, social anxieties, and so on. So this was a nice proof of that idea that this is helpful for that very important subgroup of patients. Next slide. So there's many unanswered questions that research is ongoing trying to answer. One is sort of how severe are these side effects? What is the impact on blood pressure? Can this be safely done across the board in patients? What type of patients are the most appropriate? What type of patients should not receive ketamine, where they should be absolutely contraindicated? What are the best doses? What is the best route of delivery? These studies we've talked about are IV. There have been studies looking at intranasal. There's studies looking at a liquid oral application. There's a subcutaneous injection, and so on. So route of delivery, there's many different ways to give ketamine. So what is the best, and what is certainly shown the best efficacy and safety? And then I think probably the biggest question with respect to ketamine and its real viability for the future is how do we maintain the benefit? It's clear that many patients will do well with a single infusion, and it could sort of reset the system, jumpstart the recovery process. But then the real question is, what do you do at day 7 when there's a high likelihood that there'll be a relapse, maybe not back to the baseline level severity, but maybe a relapse of 50% of where the patient had been. So how do you maintain the gains? And so for some clinics, the idea is we'll just continue in a weekly fashion giving ketamine. Other clinics have adopted a twice-a-week continuation program for 8 infusions, for instance, and then do weekly infusions thereafter or monthly infusions depending on the duration. In many ways, the model could be what's done in the community for ECT. ECT, electroconvulsive therapy, we know it can be powerfully effective and get a person out of depression quickly, even a suicidal depression, but there are high rates of relapse. And so how do you maintain the wellness after this acute effort? That I think that's the key question. Next slide. So this is just an example of the so-called dissociative side effects. And what do we mean by dissociation? Often it's a sense of being outside of one's body, outside of one's skin, looking down at the world from up high, things in slow motion, things are unreal, and sense of the body change. What this graphic shows is this is very common, but it's transient. So during a 40-minute infusion, patients will have this, but almost in every patient, by 1 hour after the infusion, these symptoms go away. So in clinical practice, what people do is they usually have an hour observation period, and then assuming everything has gone back to baseline, the patient is free to go home. It's often recommended that they have somebody accompany them, don't drive, and so on, but each practice does it a little differently. Next slide. So this is sort of getting at the idea, how do you maintain the benefit of the first infusion? And so this was a study I was involved in at Mount Sinai, led by James Murrow, and it's looking at doing ketamine like you treat ECT. ECT in this country is done Monday, Wednesday, Friday, Monday, Wednesday, Friday, usually anywhere from 6 to 12 sessions, maybe longer. And so this was doing 6 infusions over 2 weeks. And what was found was essentially if you did well with the initial infusion, you could maintain the wellness during the 2-week period by getting repeated infusions. The caveat is almost everybody relapsed, and it took about 2.5 weeks to relapse. But relapse without maintenance therapy or medications, it was inevitable that everybody relapsed. Next slide. This was a study also looking at repeated infusions. They did 6 infusions over 2 weeks. And in contrast to the previous study in which patients who did well, many patients did well at the very beginning after the first infusion and remained well, this study, patients had a progressive accrual of benefit over time. So you could see that the cumulative proportion of patients who responded and remitted increased over time, suggesting that if you don't do well at the first infusion, maybe you should continue with it for infusion number 2. There's still a chance that there'll be a response. Next slide. So the question is, from this paper, what is the ideal number of times per week for an acute treatment? Is it twice a week or 3 times a week? And this paper showed that twice a week was just as good as the more intensive 3 times a week. So that's an important finding for community practice. If twice a week is just as good as 3 times a week, certainly you want to go with the lesser number of acute treatments. Next slide. And what happens to the dissociation over time? Does the dissociation get better with repeated treatments? And the suggestion from this study is yes. There tends to be a diminishing dissociative response over the course of the treatment. Next slide. So all of the studies we've talked about so far were done in highly specialized tertiary medical centers with active placebo or saline placebo by academicians, by and large, or government employees at the NIH. So what about the real world? Where is ketamine being done, and so on? There is an advocacy network called Ketamine Advocacy Network. They have a website. It was founded by a Dennis Hartman, who is a former ketamine trial study patient from the NIMH studies who had this remarkable response to ketamine, and it then became his real life mission to introduce patients to this treatment and to vet treatment centers for quality control and so on. And so his website gives a map of where ketamine is offered around the country. He's the ones that he lists on his website have been personally vetted by him in terms of, are they using evidence-based practice? Are they using good measures of quality control? Is the dosing within accepted parameters? I think he even looks at costs. Are the costs acceptable? At this point, insurance is generally not covering the cost of a ketamine infusion, with some exceptions. Yale New Haven Hospital, for instance, has negotiated with insurance to cover a good part of that, is my understanding. And several other centers have started that process, but by and large in the community, it is a fee-for-service type treatment. Next slide. And this is from the ketamine clinic in Los Angeles, just an example of what the setup looks like, sitting in a reclining chair and just getting the infusion, usually in a room with muted lighting. And patients are just told to relax. You don't want to have any sort of stimuli during the infusion that could be overactivating. Next slide. And that's just an example of what the setup looks like. Next slide. Not unlike a person getting an infusion for dermatological conditions, cancer disorders, etc. And there's still no great guidelines for clinical practitioners. This is a paper that's in press now, led by Dr. Senakora at Yale, and it was an APA task force, which I was a part of, that came up with some recommendations for the field on what are considered best practices, although recognizing this is off-label use, so it's still not FDA approved in its current form. Next slide. There's also been a big push because of this NMDA story and how the ketamine story's played out since over the last 10 years. There's been a lot of pharmaceutical industry interest in developing ketamine-like drugs that may work on different parts of the glutamate circuits, NMDA circuits, but perhaps don't have abuse liability, may not have some of the addictive properties, may not have some of the issues that make ketamine potentially problematic for widespread use. And so this is just a list of studies and compounds by a variety of manufacturers that are in development and in phases. Phase 2 meaning small studies in the disease population, phase 3 meaning the very large studies prior to FDA approval. Next slide. And one of the ones being developed by Johnson & Johnson, which is the furthest along in development, this is phase 3 right now. This is using S-ketamine, which is it's chemically similar to the ketamine we've been talking about. It's used in Europe as an anesthetic. They're developing it as an intranasal applicator to still be used in the medical setting under supervision, but avoiding the need for a blood stick and IV. Next slide. And next slide. So the next couple slides are just some of the drugs in the pipeline, and we'll skip the next slide. And we'll skip this as well. I think the message from those couple slides is that there's a lot going on in the research area trying to take advantage of this NMDA link to rapid antidepressant. Now, many of you are familiar with dextromethorphan, one of the ingredients in Robitussin, some of the cough syrups. It turns out that dextromethorphan, it works similarly to ketamine in some ways. It works on the NMDA channel, and it's an NMDA blocker. So there's been interest in this for a number of indications, including depression. Next slide. And there's a drug used in Lou Gehrig's disease called Riluzole that has multiple mechanisms of action, also implicating the glutamate family, and may work through a variety of mechanisms, although there are some negative studies as well in depression. Some positive studies, but they're relatively small. Next slide. There's a over-the-counter supplement that many of you may be familiar with called N-acetylcysteine, or NAC. It's an antioxidant drug that has been shown in relatively large studies out of Australia, to be effective in bipolar depression. It's also been tested in aging disorders, depression, PTSD, addictions, and so on. It works in broadly in glutamate neurotransmission, but in a different pathway. And the pathway, the details aren't important outside of it's not an NMDA receptor antagonist. but this is something that you probably may have run across in a health food store, and it's increasingly being used off-label for these kind of stress-related psychiatric syndromes. Next slide. Next slide. And to throw sort of a wrench in the whole idea that the ketamine works because of its impact on NMDA, this is just a quick word that the NMDA hypothesis has been called into question, and it was recently found in a very influential paper that there's an active metabolite of ketamine that actually may work via non-NMDA receptors, and there's many other things going on. So I think the mechanism of action story is very much a hot area of research. We haven't fully figured it out. Next slide. So just by way of conclusion, and then happy to take questions, is that ketamine is increasingly administered off-label. Many of these specialized clinics for bipolar depression, treatment-resistant depression, increasingly now in PTSD. There's even some data in OCD. But the caveat for all of this is we really don't have great long-term data on this, and most of the data has been very short-term. And there's many other drugs in the pipeline which over the next 5+ years, if everything goes well, there may be more drugs available to treat these illnesses. Next slide. And just a word, many of these studies have been done by some of these centers of excellence who focus in bipolar depression as well as depression, and here's a list of them there. So many of you probably live in areas that have one of these centers of excellence. Next slide. And then just a word to plug the International Bipolar Foundation. Please look at their website and continue to support their outstanding programs and services and webinars, lectures, and please make a donation. Thank you.
Thank you so much, Dr. Mathew. We really appreciate your insight and expertise in this area. As he stated, he's open for questions, and we do have one question coming in here. So this person is asking or stating repeated use of ketamine is associated with bladder complications, and if being treated 2 to 3 times a week, would this potentially increase bladder disease?
Yes, so there have been reports of cystitis, even hemorrhagic cystitis with chronic ketamine abuse. And ketamine is abused in the Far East in numbers much higher than in the U.S., in fact, and they've reported on this. This is something that's unknown. I mean, what are the implications of chronic ketamine exposure in the treatment setting for cystitis? So now all studies looking at this chronically are focused on this. In the data we have thus far, we have not seen a signal for increased rates of this, but of course the numbers are very small. So this is something the field is looking very closely at. Thank you.
Great, thank you for that answer. The next question, are CAT scans or MRIs used in any of this testing?
Well, I think a lot of in the research setting, a lot of the investigators are doing pre-treatment MRIs, morphometric, just looking at brain volumes, or functional scans, looking at activity in certain areas. But outside of the reason they're doing that is looking at predictors of response or post-treatment correlates of outcome. But clinically, there's really no indication for MRI or CAT scan for a patient who otherwise doesn't have evidence of a primary neurological condition or a dementing process.
Great, thank you. The next question, what are the benefits of S-ketamine versus RS-ketamine? Maybe you can explain the difference.
Yeah. Yeah, so the ketamine that I was talking about primarily is the so-called RS, racemic ketamine. S-ketamine is the S isomer, and it is more potent at the NMDA receptor, allowing for lower doses. So one purported advantage would be the ability to use lower doses. Now, it's being formulated intranasally. There certainly may be some advantages of that approach over IV, but to my knowledge, there haven't been sort of head-to-head efficacy comparisons of the S-ketamine versus the regular racemic ketamine. So if S-ketamine does get approved for use, it'll be interesting to see what the comparative use of that approach versus the ongoing use of racemic ketamine is in the community.
Excellent, thank you. The next question, based off chronic ketamine abuse, can we gather any information about potential side effects of long-term use?
I'm not sure I understand. Is the question, are we gathering as a field the chronic side effect data?
Well, just based on the abuse of ketamine or any research done on ketamine abuse, can you transfer that information?
Oh, yes. So what we do know, and this study was done out of the UK primarily, is they looked at what are the cognitive effects of chronic ketamine abuse. It should be noted these were individuals who were using relatively higher doses of ketamine over a significant period of time. So these are doses magnitudes higher than what's given clinically. What was found was there were deficits in neurocognitive performance in these chronic high-dose ketamine abusers, including impairments in verbal learning, visual learning, as well as other tests of attention and cognition. So the issues of its impact on cognition is a really important area where the field is collecting this data. But I think the caveat is it's often hard to compare these severe abusers of ketamine with the patients that we're talking about who come into treatment. One reason is ketamine abusers just rarely abuse ketamine. They may use it in conjunction with cocaine, certainly alcohol abuse, marijuana, nicotine, etc. So isolating the impact of ketamine on cognition can be a challenge.
Excellent, thank you. The next question is, this person did not hear you mention lithium's effect on reducing suicide. And let's see, lithium also works on, or LI also works on CA channels, as ketamine seems to do. Is there a correlation? Maybe you can explain that.
Yeah, so lithium, there's two drugs in psychiatry that have clearly shown impact on suicide. One is clozapine, which in fact has an FDA approval for decreasing suicide risk in patients with schizophrenia or schizoaffective disorder. The other is lithium, and lithium clearly has shown a benefit on suicide in patients with bipolar disorder, but also in some studies irrespective of diagnosis. And there's a wealth of data on lithium. Now, with respect to lithium and ketamine, there have been some studies looking at lithium in conjunction with ketamine, and could lithium be important in decreasing the relapse following ketamine? And so those studies are still being worked out, but there are some mechanistic reasons to think there may be some synergy between ketamine and lithium. So that's an intriguing idea. What we do clinically often is, if they've never had a trial of lithium and they remain at suicidal risk, we definitely propose a trial of lithium. And an advantage of lithium plus ketamine, there's no reason, I mean, often clinicians are reluctant to prescribe lithium during a course of ECT. There's a feeling that lithium may make the cognitive side effects worse. We don't appear to see that with the ketamine plus lithium, but obviously the numbers are much smaller.
Great, thank you for that answer. The next question. Is there any evidence yet of ketamine infusions being better than ECT for severe bouts of depression in terms of efficacy?
We'll know the answer to that for sure in about 4 years. There's never been a large head-to-head, and we're starting that study led by the Cleveland Clinic, Amit Anand, and 3 other centers. 400 patients, 200 will get ECT, 200 will get ketamine. But right now, we don't have the answer to that.
Wonderful, thank you. The next question. I had an unexpected great antidepressant response from Ceftin, a cephaloricin, but I've been told that no one is pursuing the glutamate effects of this due to the risk of C dot difference. Any comments?
In terms of the antibiotic ceftriaxone, there were some small studies. There was a study that was started at Yale for acute depression, and it was aborted very early on. And there have been a number of issues with that, and I'm not aware of any ongoing work in that area. But it is an intriguing mechanism because there is some evidence that ceftriaxone works also in the glutamate system, may enhance the reuptake of glutamate into glial cells, which may decrease glutamate-mediated toxic damage. So it's a very intriguing mechanism, but unfortunately, clinically, it has not been something that investigators have pursued.
Excellent, thank you for that answer. The next question, any commentary on the consensus paper from APA that just came out?
The paper that I was talking about? Well, I think it's definitely, I think it's good that something like that is out there because it is sort of the Wild West in terms of what people in any individual clinic may be doing. And this is not sort of a consensus guideline in that sense, but it's nice to have some statement as to what is a reasonable thing to consider for inclusion exclusion criteria, dose, number of treatments, etc.
Great, thank you. The next question, what would be the chance of an ECT as anesthetic while or during an ECT treatment or unilateral?
Yeah.
I think there might be some word missing. Is that clear?
Yeah, so ketamine, of course, being an anesthetic, many ECT practitioners have started to use ketamine as an anesthetic agent during the ECT. The data on that is mixed, whether or not using ketamine anesthesia is better than using other forms of ketamine. It hasn't definitively shown to be better than the usual anesthetic agents. And it may be because we need the low doses here to have the true antidepressant mechanisms.
Great, thank you. The next question is a follow-up from the previous answer. Are there any additional plans to provide more recommendations in the future from the APA task force, or is this a singular effort?
I'm not aware of any task for a follow-up paper at this point, but the Council of Research of APA certainly will look at the need for that. And as more data in the field accrues, and there's a lot of data that's come out even since that paper was published that's relevant to this, I think the more recommendations will be forthcoming.
Wonderful, thank you. The next question, I hope I pronounced this correctly. Could memantine memantine or amantadine be used in any way to improve depressive symptoms, even as an adjunct?
Amantadine?
Yes.
Yeah. So amantadine has weak NMDA properties, and there have been definitely some reports, some case series about amantadine. It's something that I use in my practice for some treatment-resistant patients, but we just don't have large-scale data on that.
Excellent, thank you. The last question, how would someone join a study with the NIH if you happen to know?
With the NIH, just go onto the NIMH website, nimh.gov, and they would make the arrangements there.
Wonderful, thank you. Dr. Mathew, we're so thankful and grateful for you sharing your insight today with us. And I want to thank you all for joining us as well. And we hope to see you at the next webinar. And don't forget that this webinar is being recorded and will be posted on our website for further review or to share as well. Everyone have a great day.
Thank you very much.